Good morning, everybody. I'm so excited to be here to talk about this very taboo topic. This is a topic that is near and dear to my heart, so I'm going to jump right to the personal aspect of it. If I want you as IBD nurses and nurse practitioners and hopefully future physician assistants to be able to talk about very personal topics such as sex, infertility, intimacy, pregnancy with your patients, then I feel that it's important that I be open about my story, about how I got here. So briefly, when I was 19, I was diagnosed with Crohn's colitis, and my boyfriend at the time, boyfriend of 1 year, thought that he sexually transmitted it to me. So he didn't talk to me for about 2 months. And it's sort of funny, but it's sort of not, because this is very common. A lot of people don't understand IBD in terms of dating and sex, and there's a lot of issues and a lot of questions to be asked, and I really feel that we can make a difference as IBD nurses and providers in bringing up these taboo and personal topics and helping our patients move forward in terms of dating and sex and intimacy. All right. So my objectives today are to recognize the impact of IBD on intimacy and sexuality, as well as to use the tools necessary to discuss the topic of intimacy with IBD patients and if they choose to bring their partners to clinic. So as you all know, there's many physical and emotional issues associated with IBD. But there are not many studies on sexuality and IBD. A literature review that I did to do this presentation yielded very minimal number of results, perhaps maybe 10 in the last 10 years that were pertinent. Also, gastroenterologists treat the gut only. So when I was preparing for this talk, I asked my 3 practicing gastroenterologists in our medical group if they ever addressed this topic, and all of them said no. They have never brought this up. And that's a big deal. These are gastroenterologists who, like I said, are just treating the gut, just, giving medications and doing scopes and so busy with, surgery referrals and all of that. This is such an important topic, and nobody is asking any of these questions or bringing this up in my practice, at least. So hopefully yours is better, or yours will become better after this talk. And finally, patients don't bring this topic up on their own. A lot of patients are there to gather information, or they're scared. They're new patients with IBD. We're talking about really serious topics such as biologic medications. They're not going to bring up sexuality and intimacy unless you ask them. How many of you during phone triage get to know your patients really well? I mean, these are patients, I call them career patients. I mean, you treat IBD patients for your whole career at a gastroenterology practice. They are chronic. We have patients we've had for 5, 10, 15, 20 plus years. So I know there's barriers and borders that we try not to cross as a provider. So the patient-provider barrier, you don't want to, get too personal with your patients, but at the same time, they're probably asking you about your kids and your family and what are you doing for the holidays, and so why can't you ask them how they're feeling about their sexuality and their intimacy? So I think this is, if this isn't something that our gastroenterologists are going to do, then it's up to us as advanced practice providers who perhaps have more time with patients, more clinic visits with patients to go over these important topics. So 35 to 58% of patients with IBD report impaired sexual functioning due to their diagnosis. So like I said, you can make a difference in these issues which affect the majority of our patients. Factors that affect intimacy in IBD. The first one is a big one, age at diagnosis. As you all know, there's a bimodal distribution of diagnosis. We're getting patients who are teenagers and young adults in their 20s, college age, getting diagnosed, almost as a little more than we are getting people in their 50s and 60s diagnosed. With that being said, getting diagnosed as a teenager, I was 19, or in college like I was, that is a time of discovering sexuality, of dating, of thinking about, finding a partner for your life, whatever you may be doing. Some people at that age are, really experimental, and it's to be diagnosed with Crohn's disease, to have fistulas, to talk about ostomies, all of those things have a huge impact on these young people and can really shape the future of their sexuality. Also, disease symptoms really impact intimacy. So weight being a huge issue, whether your patient is gaining weight due to steroid use or losing weight due to being so sick, weight has a huge impact on body image and perception, and therefore impacts sexuality and intimacy. Symptoms such as incontinence, flatulence, leakage, and fistulas, these are obvious symptoms. I don't need to go into detail to explain how a perianal fistula might affect somebody who wants to be sexually active that evening. I mean, these are huge things affecting IBD sexuality. And then finally, the things we don't think about as much, extraintestinal manifestations. Maybe your patient has a skin rash or they have joint pain, and it's just making them feel like they just don't want to have sex today. So oral cavity lesions can affect someone's desire to kiss and have oral sex. So all of these extraintestinal manifestations affect intimacy as well. So body image issues in IBD affect more female patients than male patients, just like in non-IBD populations, more females tend to have issues with sexuality and body image than do males. 70% of Crohn's disease patients and 60% of ulcerative colitis patients report concerns with their body image. And to no surprise, 100%, nearly 100% of stoma patients have body image concerns. And then finally, for this topic I consulted, we have a practicing psychologist who specializes in IBD in our practice, who we all refer to, and people come get therapy with her on this, as part of their multidisciplinary care. Her biggest issue that she sees is comorbid depression. So people who have IBD are more likely to be depressed, and those who are depressed are more likely to be on an antidepressant. Antidepressants affect libido, can affect weight. So it all goes hand in hand. Depression and IBD and intimacy are all on the same, all part of the same issue. So other factors impacting intimacy and sexuality, medications. So steroids, as I mentioned, steroid side effects, acne, weight gain, the buffalo hump that they say, mood swings, those all impact relationships and sexuality. And then biologics. People who take biologics are more likely to have problems with their intimacy, but at the same time, people taking biologics presumably might be more likely to have severe IBD than somebody who's not on a biologic. Dosing regimens are a huge issue. I know it's nonchalant for us to prescribe rectal hydrocortisone, rectal kinasa, the ASAs that you can use topically, but if you think about it, you're asking a teenager or someone in their early 20s to go to the bathroom before bedtime and insert something into their rectum. That's a taboo thing for some people. And then also it impacts the timing of sex. So people are thinking about having sex at night. They're not sure, when should I use this suppository? What if I put it in before I have sex? Will it fall out while I have sex? Will it leak? I'm sure your patients have told you that some of those medications can leak out of their bottom. So these are the timing of dosing regimens is a big deal. And then injections can leave scars and bruises and things like that. So patients are pretty insecure about injectables and IV dosing at times. And I mentioned some of the side effects already of steroids being probably the most side effect ridden of all the treatments. And then surgeries and hospitalizations have an effect on active disease, or have an effect on intimacy. So for people in active disease, they have more impaired sexual function. That's not a surprise. Ostomy issues are a huge deal. Like I mentioned a little bit earlier, people who have ostomies are more insecure with their body image. Wound care, anybody with perianal abscesses or active wounds are going to have an impact on their sexuality. Scars from prior surgery, this is a huge deal, scars and ostomies. How many of you have seen on TV or on the internet those websites offering bikinis for people with ostomies, or special types of lingerie to cover up scars and ostomies? I know I have, and those sound really funny, but they're a big deal and very helpful for our patients. So we can always recommend those types of things. They make lingerie specifically for IBD patients. And also in social media, Instagram and Twitter, it's very cool. It's becoming very cool to show off your ostomy at the beach, and I love that because it's a part of who these patients are forever. Whether the ostomy is reversed and they have a scar, or they have their ostomy forever, I think it's really great. Social media is helping our patient population in that aspect. And then finally, a big deal is damage to pelvic nerves. Men and women who have surgery, especially low near the rectum, can develop problems getting aroused. Men can have erectile dysfunction. Things like that are very closely related to sexuality. I'm going to talk about women's issues. I think our population in this room today is mostly women. So fertility. There are similar rates of infertility in IBD and non-IBD patients. So I have seen some studies showing that it takes a little longer for IBD patients to get pregnant. That's because of scar tissue in the peritoneum and in the abdomen from having had flare-ups that can affect the ability for the egg to come down into the uterus and for sperm to meet the egg, etc. Slightly more rates of ectopic pregnancies, but overall infertility, the inability to get pregnant, is equivalent in IBD and non-IBD patients. Men have lower semen quality during flare-ups or with poor nutritional status, such as your UC patient who's having diarrhea 20 times a day. And sulfasalazine can cause low sperm counts, but it resolves pretty quickly after 3 months. So men who are trying to get pregnant with their partner, this is a topic to discuss, is maybe we should change therapy temporarily to help their partner get pregnant. Pregnancy. Pregnancy carries the rule of threes. I'm sure you've heard 33% of women who are pregnant get worse during pregnancy, usually during the first trimester. 33% stay the same, 33% will improve. My gastroenterologist, before I got pregnant with my baby, said the most important thing going into it was to be in remission when you start a pregnancy. So it's hard for women who are eager to get pregnant to follow that rule, but you want to make sure your patients are as healthy as they can be, that they're really truly optimized going into a pregnancy to make sure they have the best outcomes. And then this was a very interesting statistic. Women in remission can expect the same rates of pregnancy complications. However, women with IBD are 1.5 times more likely to have a C-section regardless of perianal disease activity. So that means that our OBGYNs are freaking out about the IBD patients, and they're sending them to C-section just because they're worried about the healing of the perianal area after a vaginal delivery. Yet our research is showing that for a lot of patients, they don't necessarily have to have a C-section. You can have vaginal deliveries with IBD. Oral contraceptive pills. I just wanted to put some information in my talk about this. Oral contraceptive pills cause a hypercoagulable state, as does IBD, as does being admitted to the hospital with an IBD flare. Something to think about together. The risks grow with using these risk factors together. So have caution in patients who are on oral contraceptive pills and have IBD. Have a low threshold for clots, getting people Doppler ultrasounds of their legs or screening for PEs. One should have a lower threshold for going ahead and getting the diagnostic testing for these conditions. And also, oral contraceptive pills are not suggested in IBD patients who have PSC. And then painful intercourse is a big deal. 70% of Crohn's disease patients and 25% of UC patients will require surgery in the 10 to 20 years after their diagnosis. That's something Michelle touched on. 26% of women complain of painful intercourse after having had surgery, and 49% complain of vaginal discharge. In terms of the vaginal discharge, I'm not sure what the actual mechanism of action is where they get increased vaginal discharge. It's not infective. They just tend to have more discharge after surgery, perhaps due to damage or changes in the nerves and the vasculature of the pelvis. And then finally, Pap smears. This is very important for those of you involved in health maintenance. Anybody who's immunosuppressed is more likely to have HPV come out and cause dysplasia. So they're more likely to have abnormal pap smears and infection and progression to cervical cancer. So all those health maintenance things that you think about for traditional women, you want to think about them a little more strongly for women with IBD. So desire and satisfaction, I'm going to talk about sex specifically now. In a study of 555 people, half of men and 1/3 of women reported reduced desire and lower satisfaction with sex compared to their healthy controls. Body image, as I've talked about a bunch already today, out of 330 people with IBD, body image dissatisfaction is associated with disease activity. That's significant. Steroid treatment is significant, but not related to immunotherapy and not related to biologics. So that's good. And then finally, this is really going to get super taboo here, super personal. So prepare yourselves. This is a shocker, this part of my talk. So anal sex and IBD is a tough topic. People, whether you, what you personally think about anal sex is one thing, but your patients, some of them are going to try to have it. If they have perianal disease, it's high risk for infections and tears and poorly healing wounds down there. So this is something that you want to talk about with your patients. Ask them if they're having anal sex, and I'll give you some examples of how to ask about this in an upcoming slide. This is the big one. Inappropriate uses of ostomies. Nobody in my gastroenterology practice of 15 gastroenterologists, 3 of whom are IBD doctors, and 3 PAs that work with us, nobody had ever heard of or thought of the idea that somebody would put something in their ostomy. So I know that some of the body orifices are meant to be one way or two way, whatever. We won't get into that today. But ostomies, I can tell you, are absolutely one way path. The only thing that should go into an ostomy is a scope. Okay, so patients are using them for sex and pleasure. And then finally, alternatives to intercourse. You can find a lot of information about this through the CCFA and a lot of good websites out there, but you don't have to have sex. It's okay to do other things, kiss and cuddle, whatever your patients want to do. It's not always about sex. There's other ways to get intimate. Dating tips. So this is something that obviously I experienced. So it's important to be confident to tell your partner about their diagnosis and offer to have dates at places where you know where the bathrooms are. Have you ever seen those cards at the GI practices? It's a bathroom pass that you can get in any bathroom if you need to, even if, like in Europe, they charge to use the restroom sometimes, or, you've been to a restaurant that says bathrooms are only for the people who are eating at that restaurant. Well, there's bathroom passes that you can show. I don't know if they work, but at that point, I would think that they have to let you in to use the restroom if you're showing some kind of card. It's kind of like embarrassing to say no to somebody who really needs to use the restroom, but going to dates in places where you know where there are bathrooms, packing an IBD kit for sleepovers, so making sure that you bring your medication. Baby wipes are huge for keeping clean down there, changes of clothes, hand sanitizer, etc. So packing like an emergency kit when you are dating. And then don't take it personally if someone judges you or doesn't want to date you because of your diagnosis. You wouldn't want to be with that person anyway. So in my case, where my boyfriend at the time, who didn't really want to talk to me for 2 months because of my IBD, he did eventually come around. He's now my husband and we have a baby together. But I firmly believe that if someone doesn't want to be with you because of your IBD or because of your ostomy, you don't want to be with them anyway. You wait till they're old and, not so cute and they've got, whatever kinds of, conditions or gray hair or whatever it may be that is not as attractive to you. I don't know. It'll come around and bite them. So you want to be with somebody who loves you for you. And it's okay to avoid intimacy if you're not feeling well, and the right person will love you no matter what. So what can you do? So encourage your patients to bring up sexual concerns with their gastroenterologist, and even more so with their surgeon, because as I mentioned earlier in the talk, surgery is very closely related to intimacy and impotence and erectile dysfunction, etc. So maybe you're not comfortable, your patient's like, hey, what are you doing for the holidays? And you're not comfortable saying, hey, how's intimacy? How's your sex life? You can at least mention on the phone triage or in clinic with them, I don't know what your personal situation is right now, but if you are having sex, if you're intimate with somebody, it's a really good time to bring that up with your gastroenterologist or with your surgeon. So if you don't, as a nurse or whatever, don't feel comfortable talking about that, remind your patients to bring them up with their doctors. Discuss all medication side effects with patients. So if you're giving someone a short course of steroids, let them know what possible side effects they might have, in terms of their libido. Connect patients with psychologists and psychotherapists for a multidisciplinary approach, just like we have at our practice, getting patients connected to special therapists who can talk about these issues so that you don't have to if you don't want to or don't have time to or aren't in the right situation to do so. Sometimes the telephone in a busy office for triage isn't the best time to ask about sex, I understand. And then finally, providing patients with brochures, reading material, blogs, Instagram handles, support groups, web links, etc., other resources. Maybe they don't want to talk to you, but when they go home, they might want to look some things up and feel better in the comfort of their own home looking up these topics. So how to ask about sex. Let's say you are a nurse practitioner or you are doing an infusion and you have a private room and you're able to ask your patient casually about their sex life. How do you ask? So you can say, are you and your partner having sex? That's a good way, open-ended question to see what they say. They may say, yes, everything's fine, don't ask me about this. Or they might, want to elaborate more. You'd be surprised how much people are willing to talk to you. And are you currently sexually active? This is key with men, women, or both. It can be embarrassing to ask this question, but you have to ask because people have all different, preferences, and anal sex, as I mentioned before, is more prevalent among men with men, so you need to ask those questions. This is a really good one. There's a lot of literature about the impact of IBD on intimacy. How has IBD affected your love life? And then a reminder to keep all of your questions open-ended, broad, and vague. Patient resources, I would say the CCFA has a really good section on women's issues and intimacy, and then there's a lot of other websites and groups that can help you navigate your patient towards talking about these taboo topics. So I just want to say that I am a success story. I got my dream job in gastroenterology, and I feel that having Crohn's colitis has helped me see things from the patient perspective, and not just that, I am happily married, and my husband at this point doesn't care about my IBD, so I think that there are some really good success stories out there, and it's not the end of the world getting an ostomy, it's not the end of the world getting, a fistula or having a bad flare or being hospitalized. There is, a light at the end of the tunnel and a bucket of gold at the end of the rainbow, whatever you want to say. But I really enjoyed talking to you guys, and please don't be embarrassed or ashamed to get in touch with me if you have any questions about how to approach these interesting and personal topics with your patients. Thank you.